And welcome to the show. I'm Jim Flyzik. During today's show, we will discuss critical issues facing government and industry leaders in using information technology to improve healthcare and healthcare services. With me today on the show are Dr. Doug Fridsma, the Director, Office of Interoperability and Standards, Office of the National Coordinator for Health Information Technology, Colonel Han Pak, the Chief Information Officer, MEDCOM G6 at the U.S. Army, Chuck Hume, the Customer Advocate for Health at the Department of Veterans Affairs, Ray Sullivan, the Vice President for Healthcare Solutions, General Dynamics Information Technology, Tom Conway, the Director of Federal Business Development at McAfee, and Dr. Michael Cowan, the Director for Federal Healthcare Practice at Deloitte, and also the 34th, formerly the 34th Surgeon General of the Navy. Let's get into today's issues. Let's first talk to each panelist, get a little idea of your role and some of the progress you're making in your respective area. We'll start with Dr. Doug Fridsma. Can you tell us at HHS what is your role and maybe some of the issues you're working and progress you're making?
So thanks so much. I'm delighted to be here. We at the Office of the National Coordinator have been working hard on a number of different issues. We have been supervising the federal health architecture, which is a mechanism to coordinate across federal agencies around health IT strategy. We've been working on the Nationwide Health Information Network, a way for both federal as well as private sector members to be able to participate in information exchange. And we've been expanding not only the participation in that, but also the kinds of services and the kinds of information exchange that can occur. We've been also working very hard at expanding excuse me, the role of governance in that. We would like to move the NWHIN from a pilot into something that has more national scale, and we've been working on that as well. And as part of our meaningful use activities, we have state beacon programs and others that are trying to develop the conditions of trusted exchange that will protect the information that gets exchanged among patients, and also to provide more access to that in terms of providers and other people taking care of patients. Yeah,
great. Sounds like a lot of great stuff going on. Appreciate that. We'll come back and drill down on some of those things as we move along. Colonel Pak, how about your role at the Army? What is your role and some of the issues you're working on related to health IT?
Right now, in my current role, a lot of my time is spent on EHR modernization. Obviously, I do that as one service of many, including Air Force and Navy, of course, and now working with the VA to really figure out how we jointly modernize our electronic health record to support our larger mission. So that's been a tremendous effort, especially in the last year to 2 years. The other effort internal to the AMED is the establishment of the informatics workforce, because what we realize is that no matter what IT you put in, you really need the workforce that understands and has a deep understanding of the workflow, what it is that we're trying to do, and incorporate the right technology in the right setting, and along with training. Business intelligence is the other critical piece that we've been working on, and to develop a robust business intelligence and analytic strategy to figure out how do you mine the data from the electronic health record that is now fully implemented in DoD, and how do you then now make that into actionable information delivered in the right way, in the right context for our providers and our leaders to make best business decisions. And probably the last thing, and probably the most important thing, is what my Surgeon General has asked me to do, is to regain the trust. And I think within that context, it really means that bringing IT back on the table of leaders to be a business driver and a strategic thinker rather than thinking purely about the infrastructure and those issues.
I think that's a great point. You know, it's a lot of trust related and a lot of other issues other than just the IT associated with moving this stuff out, you know. And a lot of issues are going to have to be overcome and process change and so forth. Tom Conway at McAfee, give us a little snapshot of your role and the kinds of things you're working to improve the use of technology for healthcare.
Thanks, Jim. As we all know, that the federal government continues to exhibit a lot of influence on the larger health IT market, not just the federal government, but the commercial and state and local as well. This manifests itself in a number of different ways. You look at large historical programs such as Medicaid and Medicare. Then you look at the great work being done in the VA and MHS to pioneer things like electronic health records, universal adoption. Then you also look at the new regulatory frameworks and incentive payments that are coming out of ONC. So a few years back, McAfee made the decision we're going to verticalize health within our corporation, and they decided to put it under the public sector group, of which I'm part of, to basically give us visibility as things start, whether they come from a programmatic standpoint, a technology standpoint, like EHR, or an incentive or a regulatory framework as is coming out of ONC, so we can better serve our clients, whether they be commercial, whether they be state and local based, or whether they be federal based. So my role is to sort of look at all that, bring it together, and help us put together a strategy that serves all those health IT sub-segments under the larger segment.
Oh, okay, good. It's, I guess, you know, health IT became such a hot topic. A lot of companies had to do some adjusting to position themselves well to support the government in those areas. Dr. Cowan, how about over at GD, what is, I'm sorry, at Deloitte, what is your key role there and some of the issues you're working on?
Deloitte, of course, is a large professional services consulting company, and we have an array of services that we provide to the healthcare industry. We see health information technology as a real brass ring opportunity for health. In America, we have the finest trained physicians, we have the best technologies, but I think almost all of us would agree that our system doesn't really completely fulfill the promise of its potential. We think health information technology is a brass ring. It's an opportunity to improve cost, improve quality, and improve access using technologies mostly to communicate, to overcome the tyranny of geography where it's very difficult for information to follow patients from doctor to doctor.
Yeah, looking forward to that day. Having been the doctor a few times and filling those forms out over and over and over again. Chuck Hume, with the VA, we're happy that we have got HHS, DOD, and VA with us today, so I feel like we've covered a good landscape for the key players working a lot of the government issues. Chuck, welcome back. Your role and some of the things that you've been doing last year.
Thanks, Jim. You know, you're exactly right. And the three government organizations being here together, we're together every day, working on things to improve federal healthcare IT and federal healthcare. You know, a big project for the VA in the last year has been our Blue Button project, part of My Healthy Vet, to empower veterans with more information, enabling them to gain access to their electronic medical record that we have captured over a long time through our VISTA system. We added that in the last year and keep on adding data fields to that veterans can download to make sure that they know everything about what's in their health record and can share that with other providers that they go see. We're also working with HHS and the Department of Defense to advance the virtual lifetime electronic record. The big emphasis on that right now is the sharing of health information with private providers. Both VA and Department of Defense, their beneficiaries get health care from internal to our systems and from providers outside of our systems. And so we want to work toward capturing a more complete medical record on all of our veterans, and that includes the data from private providers.
Yeah, terrific. Thanks. And we'll, again, drill down on some of that, talk a little bit more about these things. Ray Sullivan at General Dynamics. Can you talk a little bit about your role and the kind of things you're working on related to healthcare?
Thank you, Jim. Yeah, in regards to GDIT, we don't actually deliver care, but we do have a great deal of expertise coordinating, facilitating, normalizing, managing, and securing data to help these agencies achieve their goals and directions. We are currently doing work in each one of the agencies represented here. My role in GD is to serve as a subject matter expert in the areas of healthcare, help set the strategic plan and align our offerings with the challenges, goals, and objectives of the agencies that are represented here.
Good, good, terrific. We'll, again, talk a little bit more about that too. Let's switch now and talk about some of the areas that we think are the biggest opportunities, places where we think we can really do something by using health IT or IT to support healthcare to really create some big opportunities for improvement. Let's start with Colonel Pak this time. Colonel, where do you see some opportunities that are, where we can really make some differences?
I believe that as I try to look into the crystal ball, I believe that there are probably some safe ones, and then there's some things that may not be as clear. One is the mobile technologies and telehealth. I believe that all the external factors and the drivers for healthcare reform and the meaningful use, all those things to try to get us towards reducing or being more efficient in terms of healthcare delivery can only be achieved when we get towards more of those technologies incorporated that support personalized medicine, that empowers the patient, that changes their behavior from a social setting, because we know that 70+% of the cost is really in the chronic disease and those things that really require patients to be in a much more empowered setting and be incentivized to change behaviors at the end of the day. So I think that mobile technologies and telehealth, I say that because I believe that as we now have a increased population coming into the healthcare being insured now, that will require more specialty care and so forth. And in order to get to the geographic disparity issues, you need a way of virtually connecting the patients to the right physician, whether it's a specialist or primary care. So I think I'll stop there.
Yeah, good. I think too, once you do have that, it's sort of like a knowledge sharing thing. When you get everyone connected together there, you can pull from the smartest minds for different subjects. Chuck, what do you think are some areas where there's some real big opportunities to make a difference?
Well, the biggest project we've got going on right now is the integrated electronic health record with the Department of Defense. For 12 or more years, we've been sharing information between the two departments. There's a natural flow. I mean, it exists with the transition from service member to become veteran. So there's a natural transition there of the individual and a natural transition of their information. So we've been working on that sharing of information for some time, but we've been doing it the hard way. We've been building essentially a bridge for every data element from one electronic health record system to the other system. Both departments right now are on the verge of modernizing their record systems that have been in place for some time, and so the secretaries have agreed to do that together. And so we can benefit from the standardization of data, the standardization of the representation of that data, and the way it's displayed to the provider to improve healthcare through decision support and computing on that data between the two departments, because essentially we'll be using the same system. So I think that's a big advance we're going to see.
Yeah, I know there's been a lot of effort to try to harmonize a lot of the data amongst the two. Colonel Pak, you had a comment on that?
I just wanted to add on to what Chuck just articulated. I think the impact isn't just federal. I think this is a very important point. What we're about to do, if we're successful, and we're planning on being successful, is that decision support, all the things that we're building, especially in partnering with HHS and the larger community, will be able to deliver capabilities and content in ways that can't be done today. It will have a huge implication for changing an industry from a large, tightly integrated industry or companies to a more modular type, where you will increase competition and I think at the end of the day bring better value.
Yeah, I think that's a good point. And I think with mobility and with the things we're doing here, I think there's got to be a way to start moving this stuff around a lot more efficiently. And I can't wait, having just had some surgery and the number of pieces of paper I had to fill out. Dr. Fridsma, Doug, what do you see as some of the key areas where some opportunities are sitting there that if we can, go after them, we can make some big differences?
Well, I think, the current way that electronic health records communicate is through something called a printer, where an electronic health record prints out something, that record goes into a fax machine that then goes to a scanner and back into an electronic health record. And a lot of what we're trying to do is actually begin to build those bridges so that we don't have to go through paper as these things communicate.
Right. Sounds like about 3 or 4 devices there that might not be necessary in the future.
Exactly. And our strategy is that first thing you have to do is you have to get the information in electrons. So once you get it in electrons, then you're able to do useful things with it. So our approach with meaningful use is to get physicians and providers to start using electronic health records. then develop standards in collaboration with their federal partners so that we can begin moving that information around as the patients move to different care providers. And then finally, as we have that information in an electronic format and is accessible across the healthcare system, making it useful through decision support or providing additional ways in which that information can be leveraged for improving safety and the quality of care.
Yeah, terrific. Well said. I like that. Let's switch to our private sector folks here. Ray Sullivan, how does GD, how do you look at opportunities to support your government clients? Where do you see the big opportunities to make big differences?
Well, I think there are obviously a lot of challenges, and if we use what DoD and VA have done as a case history, you can see some of the challenges we're going to be facing as a nation as we begin to achieve a national healthcare solution. And I think in reviewing what the lessons learned have been is, normalizing the data, bringing that data together, managing it, securing it, making it available to the right people at the right time, at the right place, are going to be some of the challenges. The opportunities, I think, are once that database is in place, the opportunities for predictive modeling and utilizing that data in ways that we can't do today are some of our greatest opportunities.
Yeah, I think so too. You know, I sometimes think that if we can just get the data into, as Dr. Fridsma said, electronic format and usable format, it's like the apps on these handheld devices. You know, we can't even imagine some of the things that can come about, and I think it'll create a whole new world of creative and innovative thinkers coming up with ideas to do things. Dr. Cowan, how about at Deloitte? How do you guys view the biggest opportunities or the areas you think that the biggest opportunities will be?
I would certainly agree that the electronic health record and the interoperability of data, not only between people within a system, but between systems and between the public and private sector, are fundamental. That's vital. I get excited about some other large opportunities that actually use the lower end of the technological scale, very simple technologies that have the promise to add great value. For example, today most people in private practice live in information deserts. It's very difficult to get information between practitioners. Most patients see more than one practitioner, so a very common problem is using a lot of valuable time chasing down information or redoing laboratory tests, et cetera. Both the military health system and the VA are in the process of implementing a concept called medical home, where an individual patient signs up to have a primary care doctor. That relationship is supported not only by the EHR, but by a PHR and a patient portal and a secure emailing capability, allowing the doctor to be the friend, ombudsman, agent, as well as the physician for that patient, and move information around effectively and efficiently. Technology is all here. It's all very simple. Both departments are in the middle of doing this, and the increases in value and the savings of cost have great promise. We're very excited about it.
Yeah, it sounds great. It sounds like there's an awful lot of things that can be done relatively easily. I mean, the technology's there. Tom, I do want to hear from you, but before we do that, we need to take a short break. You're listening to the Federal Executive Forum on Federal News Radio, 1500 AM. Federal Executive Forum on Federal News Radio, 1500 AM. I'm Jim Flyzik, here with Dr. Doug Fridsma from the National Coordinator's Office for Health IT, with Colonel Pak from the Army, Chuck Hume from VA, Ray Sullivan from General Dynamics, Tom Conway from McAfee, and Dr. Cowan from Deloitte. We're talking health IT. When we went to break, we were talking about opportunities, and we didn't have a chance to hear from Tom Conway over at McAfee. Tom, can you talk to us a little bit about areas you see of big opportunities to make some big differences in using health IT?
Sure, Jim. As Dr. Cowan said, I think we all agree that the overarching goals we're trying to get to is improved quality, improved cost, and improved access. And I think information technology can help in each of those areas. I'll just highlight a couple of them. If you look at access, telemedicine, it's great at serving the battlefield, underserved areas, but we should also think about the shut-ins at home care. I've got some in-laws who don't get out of the house much, they're not ambulatory, so if we could bring them in-home telemedicine, that would save a lot of money, I would think, from everybody involved and improve their quality of life. So that's a key area as well. And I think portability is the other big one, is people have more of an interest, more knowledge, more possession of their health records, so they can take their health care and make it more portable, make it more of a competitive market where the consumer has choice and is empowered. However, when you increase portability, you need to ensure security at the same time. So how do you balance access and security, portability and security? I think those are opportunities as enterprises, and also we'll go into a little bit more on terms of challenges specific to those.
And the implication for privacy and things like that. But I, for a long time, have had an argument that I have no idea where my healthcare records are over the years. I mean, the amount of papers I've filled out, the amount of doctors I've been to, places I lived, I have no idea. If from the very beginning I had an electronic card and I could keep my health records there, I actually think for the first time ever I would be in charge of my own privacy and I would have access and know where my records were. So I was always all for that. I know there's pros and cons when you get into it, but I do think security and privacy can be greatly enhanced if we go to electronic health records.
I think it can be, but the challenge is how to get there. I know my doctor knows how to work a cipher lock on the records door, room door. I'm not so sure they know how to secure their systems.
That's true. I mean, there's clearly issues which, it's a perfect lead into our next subject here. We're going to start talking about some of the challenges that we're facing in order to get to where we need to go. Start with Chuck Hume this time. Chuck, what do you think are some of the really big challenges out there, the really tough things to get to where we want to be?
Well, we're working real hard to get a complete record on an individual, on a veteran. The scary thing is, once we get that, how does the provider consume that much information in a 15-minute appointment? So, you know, we call these things electronic medical record systems, but they're much more than just a record. They're really managing that delivery of health care. And so we need to work on making our systems that much more advanced so that the system can better predict what information, the minimal amount of information that needs to be presented to the user of the system so that they can use it for the right information for decision making. We could create a record system that has so much information that it's complete information overload and really individuals can't use it anymore.
Yeah, that's good. I didn't think about that one. I guess we need not just information, but we're going to need some like business intelligence, for lack of another term, that can look at that information and highlight things that are key.
We certainly build that in today, but the volume of the job is going to increase dramatically over time.
I bet. Dr. Fridsma, what do you think are some of the real tough challenges or the constraints that still need to be overcome to get to where you want to go?
Well, I think there's a couple of things, and just to sort of follow on from Chuck's comments, one of the things that we're doing at ONC is this concept of meaningful use. So it isn't just about the technology, but it's about using that technology in ways that actually benefit patients. And so that is going to require understanding the work process, understanding how best to use the technology. And so measuring quality and doing quality performance, I think, is going to be a key part of some of the challenges that we have going forward. I think it's also important to recognize that it's not going to be one size fits all. We're not going to have a singular solution that will work across the country. We'll have sophisticated organizations like the VA and the DoD that will have big systems, and we'll have rural providers that will just need to have simple solutions that will allow them to take good care of their patients effectively. And I think over time, the biggest challenge we have, at least in the short term, is time. Consensus takes time. Standardization takes time. And so bringing people together, making sure that we've got the right solutions, creating an incremental path that allows us to start where we are now and grow to where we want to be, I think is going to be a challenge going forward.
Yeah, I know making decisions by consensus is not an easy thing from my days in there when many stories when we tried to pull together components and the first 22 components in DHS and get everybody thinking the same way. You know, I used to have a feeling that if there's more than 2 people in the room, consensus is not possible. You really need to have some people need to begin to, you need some leadership and have to hear everything out, but you have to make some decisions and move forward too. Colonel Pak, what do you think are some of the really tough issues out there, the big challenges that need to be addressed?
since we have experts on interoperability to my left and to security and privacy on the right, I think I'll pick a couple of things that maybe wouldn't come up per se. I think given my background, I have a bias towards reimbursement issues. In other words, we're still in a healthcare delivery system that incentivizes more care, more widget counting. And until that changes, until we are incentivized to take technologies that can improve the value of healthcare, until that happens, we really aren't going to get to that state. So I think that's a huge issue that is still a barrier, in my opinion. The other is culture. If you look at the challenges and the opportunities that the DoD-VA have in front of us with the IEHR, we clearly jointly see a clear end state of what that might look like. But culturally, because we grew up differently, we're in different settings, in which we have a more static versus a highly mobile environment. And when you grow up with different set of parents, different processes, policies, and to bring them together kind of in a Brady Bunch, those are very culturally diverse set of normalization that has to take place. So I think that's governance and culture are always big issues, but I think we're working through them.
Yeah, I think you're exactly right, and that's our magic word again. I kid on this show, but this is our 69th show, and I think every show we've hit on culture being a challenge somewhere along the way, no matter what the subject is. People talk about the technology is one thing, but the culture, behaviors, changing behaviors, having people change process, do things differently is a major issue that's got to be overcome. Dr. Cowan, how, when you look at this stuff, what do you think the hard things are? What's the tough things out there that need to be overcome to really make progress?
Well, first of all, there's plenty of them. There are lots of economic issues. There are the laws of unintended consequence around public policies. We've already touched on security and privacy issues. These are a number of things that all confound progress in one way or another. But I think all of those are sort of like, Harry Truman said, all questions can't be answered, but they can all be decided. So a lot of those are just getting through them. I think, and this is echoing what Colonel Pak just said, and you also, I think the biggest challenge in change is change. We have, for generations, taught our patients to be quite dependent on us and fairly passive. We've had a very patriarchal system where the doctor knows best. We are now saying to patients, we want you engaged in your care. We want you to help. We want you to have decision-making capabilities. We want you to have information. And we're saying to clinicians who have, for a long time, practiced medicine in one certain way, to do it in a different way, and sometimes to make fairly profound changes in the way they practice. It's not easy. I'm a hematologist-oncologist, and I'm retired now, but when I practiced, everything I could do to help someone could also harm them very much. And so I had a way, and I did that way every time. And if you ask me to put one foot out of place, I would become profoundly uncomfortable. So I think we're working through, you said cultural, I think that's probably as good a word as any, but we're working through the issues of change itself.
Yeah, no, change is tough. I mean, you can give somebody a different title, or you can tell them they have a different job. You can do that overnight, but to actually have them behave differently and actually begin performing in a different manner is a whole new set of challenges. Tom Conway, what do you think are some of the really tough issues that need to be overcome to get to where we need to go with health IT improvements?
Dr. Cohen mentioned, we talked about confidentiality, integrity of data, but people tend to neglect availability. History shows when we automate a process, we quickly lose the ability to replicate the manual process. So as we go to this digital future where we're completely reliant upon IT and digitized health records, you need to make sure that network is fully available 5 nines plus, because lives are at stake. So as you look across that, you need to build redundancy into the system, whether it be human redundancy in terms of training or technical redundancy, and make sure that system becomes almost like your digital dial tone, your 911 system, where it's always there. So I think that's a challenge we all need to realize, because it's going to be a highly federated system. Right. So there's going to be a lot of cross dependencies there where I'm dependent upon you, even though I don't have full control over you. So there needs to be some level of assurance in terms of availability, just like there needs to be in terms of confidentiality and integrity.
Yeah, what I'm picking up here is, it's not just about automating data, it's about process change, business process change, and to make sure that all the pieces are falling together here, because if any one of those pieces is neglected, whatever, the system could be in deep trouble quick. Mm-hmm. Let's go down to Ray Sullivan at GDIT. Ray, what are some of the areas you see as being areas that are real tough challenges out there that need to be overcome to really get to where we think we need to be?
Well, I think I agree with the comments made about the social engineering aspect of it. I think that is a significant challenge. I think VA and DOD have come a long ways in that area with both with the clinicians and as consumers, but we still have a major void in the private sector as far as utilization of electronic record and how the consumers are going to interact with that. I think things like developing a national standards, establishing them and implementing them are foundational to us moving forward. It's great that we can create these islands of electronic records, but how are we going to pull them together? I think the work around meaningful use, the work with NHIN and Connect are steps in the right direction, but I think we still got a long ways to go. We need to create a sense of confidence in the private sector if we expect clinicians to invest and adopt electronic healthcare records. I've heard comments that it's too difficult, it's too complicated. I think it's more a factor of a lack of confidence that I implement, invest in this product, and is it still going to be a player 5 years from now?
Yeah, well, I think doctors too, doctors are not used to working on computers all day long and putting information. Some of them probably view it as, something that they see as a challenge and things that, most of them, a lot that I've talked to, because in getting prepared for these shows, I just had a couple of doctor appointments and I asked them about electronic records, and, most are saying that there's a lot of hope for the future, but right now, the return on investment's not that great, because for the reasons that all of you are saying. They're implementing it in their office, but their inability to share it or move it around or interoperate with others, is hindering that return on investment that they're all looking for in the long run. And talking about that, let's talk a little bit about that interoperability and sharing of information and things, and coordination of programs, say, that are going on. We know we've got coordination in the DOD and VA and HHS, but there's so many players that involved in health. I mean, from insurance companies to doctors to hospitals to multiple other federal agencies, state agencies, the so-called NGOs and so forth. Let's talk a little bit there. Let's start this time with Colonel Pak. Colonel, how do you even begin to look at that complexity of interoperability and all these players that you need to interact with?
It's quite a complicated question, but I think that I'll take a couple of segments of that. Okay. One is from where I sit, clearly the IPO, the Interagency Program Office, along with the efforts from the White House and the HHS, we are currently coordinating our efforts around the beacon communities or beacon partners, the NWHIN efforts, the VEALER, which is connected to that. So I am beginning to see how the national programs are being connected or coordinated, at least at a minimum. Now, are they fully coordinated where the states, everything is? Not yet, but I see the beginnings of the structure and the intent that's fairly clear. I think that's just one piece. I think that when you begin to look at, okay, we recognize that the data is exploding and we need to get a better handle for how we make the huge amounts of data into information to knowledge so that it actually impacts change at the patient level or at the provider level. To begin to do that, the coordination that we've had with ARC and HHS is, can we create a collaboratory in which the clinical decision support can be done collectively on a standardized fashion so that everyone can benefit, whether you're a one or two man practice shop or a large organization like Kaiser or Geisinger's, to be able to say, okay, here's an encoded way you can download that knowledge in a way that can be consumed by their electronic health record very easily, which then can then take massive information and then make it useful for that setting for that patient. I mean, that's kind of the coordination that we're beginning to work on, but obviously these are huge problems.
Right, there are complexities there, yeah. And I know we have the Nationwide Health Information Network, I guess, is a core, and then, now how about like open standards and things like that, where, you know, there could be an app for it and things like that. Are things like that in the picture? Dr. Fridsma, do you see, you know, interoperability? How do you see that issue being addressed?
Sure. Well, I think one of the things that's important at ONC is that as we identify standards, that we need an open and inclusive process. We won't be successful if we just dictate standards. Standards aren't standards because we say they are. Standards are standards because they solve a problem and people use them. And so as part of that, we've developed a framework that engages the public. We've used kind of experts in the open source community to help us organize those communities. We found that if we focus on clear, tangible, and manageable goals, it makes it much easier to align a whole host of different activities that are going on, because you can say, our target is this. We don't need to have a meeting to decide how to get there. We can actually work all collectively towards that, and that makes it a lot easier. We also, as Colonel Pak has mentioned, we have a whole host of programs that I think engage the community. We have our state programs. We have regional extension centers that help providers actually with boots on the ground get the technology into their offices. We have the state beacon programs, which is an intent to sort of create a community of individuals and organizations that have clear quality goals that they're trying to achieve, and they're intended to be the beacons, the light leaders that everyone will follow. And we are also developing workforce programs so that we're trying to train individuals that have the skill and expertise so that the programs can be sustained over time.
Yeah, terrific. Well, I'm glad you came on the show, because I bet a lot of people don't realize all this stuff that's going on. We'll come back in a minute and pick up with the other guest here, but we first need to take a break. You're listening to the Federal Executive Forum on Federal News Radio 1500 AM. The Federal Executive Forum on Federal News Radio 1500 AM. I'm Jim Flyzik here with Dr. Doug Fridsma from the National Coordinator for Health Information Technology Office, Colonel Pak from the U.S. Army, Chuck Hume from the VA, Ray Sullivan from General Dynamics, Tom Conway from McAfee, and Dr. Michael Cowan from Deloitte. And we're talking health IT. We were talking about some of the interoperability issues and some of how to coordinate amongst all the complex organizations out there. And we just heard from Dr. Fridsma. I think Colonel Pak, you had a comment you wanted to follow up with.
I just want to add on to Doug's comments, and that is, as we look at the interoperability and the NWHIN efforts, I think perhaps people on the outside don't quite realize that that we have, particularly in DoD and also in VA, a significant part of our healthcare being delivered by the private sector.
Yeah,
so we are now in the 60 to 70% of healthcare being delivered by the civilian network, and this is why HHS and the White House is very involved in coordinating the activities, because you can imagine between the VA and DoD and the presence we have in the localities throughout the country and the world, it really gives us a way to begin to shift the market to get to that inflection point. And I think that's really what we're trying to do.
Yeah, that's a very good point. I'm glad you brought that up. Chuck Hume, what do you think in terms of, from where you sit, how do you even address that issue of all the players and interoperability and things like that that need to be dealt with?
Well, I think Colonel Pak and Dr. Fridsma and I are really talking about many of the same things here with our effort toward the virtual lifetime electronic record. We started that program focusing on health information, but the intention is to broaden that to all types of information that's needed to bring together to make decisions regarding education or jobs or benefits or any of those kinds of things. So it'll branch out to much more different kinds of information than just health information over time. But in the health information pilots, the deliberate point of doing pilots were we knew we were going to encounter different scenarios in different locations. So some places we're dealing with one hospital network that has an integrated system. In another area, we'll work with a local health information exchange that's representing multiple hospitals and multiple networks. In other locations, we're dealing with government organizations that have sponsored different health information exchanges. So we're encountering all different types of arrangements of people interested in pulling that information together and sharing it. For years, a lot of these places have wanted to share information with us in kind of a one-off, unique arrangement. But you know, the VA is all over the country, and so we needed to wait and make sure that we were working with HHS to establish the standard way that we will share information with all of these various different kinds of partners. And so that's been our effort in working with non-government organizations.
Yeah, terrific. Terrific. Well said. Thank you. Ray Sullivan, what do you think in terms of that interoperability question? You guys give it thought at GD as to how to approach that?
Well, we work with private sector, states, federal government, and it's clear that it's imperative for the private sector to be in line with what federal and state agencies are working towards, and to support those initiatives with the innovative tools and resources they need to succeed.
Yeah, good. It's tough, I know, and in some cases I think big companies need to rethink the way they're structured and things like that. When you get into these issues that cross federal, state, local, private sector boundaries, it forces companies, I think, to rethink the way they're structured and how they support government agencies. Dr. Cowan, what do you think in terms of trying to even get your hands around the complexities of all these players and to get everybody sort of like at least marching in somewhat the same direction?
I think the particulars of this have been well stated. It may be worth making a couple of comments. One is, particular for your listeners who may not follow this, the magnitude of what we are trying to do with health information technology is absolutely unprecedented. This is complex information from a wide variety of sources with multiple users all over the nation. I don't think anything of this magnitude has ever been done before. I could be wrong, but it's pretty big, even if it isn't that big. The second thing that's important, and sometimes talking and reading about this issue, you get a sense of people's frustration with progress. You know, we're not making progress very fast, but the truth is, until very recently, really the advent of the internet, World Wide Web, and modern technologies, these things were essentially impossible. We could not be looking at having the kind of interoperability that the nation is working with if we didn't have the technology that's only recently been developed. So when you think about the size, the complexity, and the newness of the technology, there's been a lot of progress made.
Yeah, actually, and I think you raised some great points too, and there are some really interesting things because it's not only the magnitude of the problem, but it's kind of like a changing dynamic set of requirements, because you know we have the Congress passing laws, arguing over different directions to go, different points of view to go, so the laws change, the rules change, and the different players involved in it. Some that you know not so obvious. I know I had dinner with the CIO from IRS, and he was telling me that the new healthcare, the amount of impacts it will have on the tax system and taxing and things like that, it creates all kinds of additional complexities there. So there's so many little things that aren't that apparent that come into play here. Tom Conway, what do you think in terms of when you think about the interoperability question and the challenges of getting everybody moving in common directions?
I think the federal government has a very key role in this. I think you see demonstrably what the VA and MHS are doing. It is a national program. I would argue that the commercial market in terms of healthcare is 54 monopolies at the state level. So the federal government is looking cross-state as interstate commerce, as it should, and promoting standards to facilitate that, with the end goal is we're going to have a more efficient market that's going to be driven by empowered consumers with portable information. Right. So I think the federal government can really provide the seed capital and the intellectual capital to really be a catalyst for that. A lot of different fronts, experimentation, VA, MHS has been doing this for a long time. power the purse. Medicaid and Medicare have a lot of money to put behind this. ONC can bring it all together with interoperability and standards.
Yeah, I had some experience with it too when I was still in government working when we wanted to have, when you do your federal income tax to be able to do your state income tax at the same time, just harmonizing that. Because all the states have different rules, different issues, different things, call things by different names, and it really gets to be what seems to be an easy thing to do turns out to be massively complicated. We're under 12 minutes left, and I always want to talk a little bit here before we end the show with your visions for the future. So what I like to do is hear from each panelist here a little bit about what do you see in the vision for the future? What do you see, where's this going? What kinds of things can we expect? And let's work our way just straight down the table here. Let's start with Ray Sullivan at GDIT. What's your crystal ball have in it, Ray, out there? What do you see in the future in this field?
Well, to me, we're very much like we were in the early days of banking when you started the drive-up window, and then you had an ATM card that would only work at certain banks, and then they worked that out. Now I manage everything online. I don't remember the last time I stepped foot in a bank. So I believe that if we do this right and our goal and objectives are achieved, that I envision the day when I have control of my electronic record and I'm able to go online, look at data that tells me where the best providers for my condition are, and I'm able to do my own referrals, where my information is available across the country. So no matter where I'm at, if I have an emergency, I walk in and I'm able to provide access to my electronic record. And I think ultimately that's the goal of all the efforts that we're pushing forward.
Yeah, I think you're right. It's sort of like it was mentioned here before, there's some responsibilities need to be taken on by the individual patient too. Chuck Hume, what do you think it looks like in the future? Where do you see this all going?
That's a great question. I mean, I caution, though, myself that the predictions of the future will only be scratching the surface, because if you set yourself back 15 years before there was an internet, before you had access to the web, you couldn't have imagined the things that you are able to do naturally today. So in time, we will do naturally things we can't even imagine being possible, or can't imagine that capability exists. But what will happen is that healthcare will be a much more team-oriented event, with including the veteran, the patient, knowing all the information that the provider has. The provider and the team surrounding the provider have all the information that on that individual. And over time, we will know through our electronic data evidence-based care that we know works, because we have that whole history of populations of records and what they presented with and how they were treated and what worked and what didn't work. And we will be delivering much better health care in the future.
Yeah, I think you're exactly right, too. I think once we get these things in an electronic format, we can't even imagine some of the things that'll be able to be done in the future. Dr. Cowan, what's it look like to you out there?
I have a very personalized individual dream for the future.
Okay.
Today, if you need medical advice, you have to call a doctor, get an appointment, drive to the doctor's office, increase your carbon footprint, sit in the waiting room, see the doctor. Doctor tells you what to do. You drive to the pharmacy, you wait there, you go home, and then you repeat PRN until your problem's solved.
Right.
The visit of the future ought to be, I need advice. I'm a patient now. I turn to my computer. I read in 10th grade English valid, vetted sources of good information. I may call on my social networks to help me think this through. Then I will IM or email some number of clinicians and expect to have a consultation with them. And then, if necessary, I would go see the doctor, but oftentimes, especially in primary care, it's not. And if it's not, I expect to come to a common consensus where I and my doctor agree on the treatment and the problem, and then I hear the satisfying plunk of the package delivered from the pharmacy with my prescription just as fast as a pizza would have come from the pizzeria.
I like that, and I like the analogies, and I think, and there's not one thing you said that's not possible in terms of, of happening in the future. Tom Conway, what do you think? What's your future look like to you?
My vision is that we have a national healthcare market which is based not on patients, but on informed, empowered consumers of medical services. Big shift. They're just not receiving. They're actively involved in their treatment as well. That has to be built upon a accessible, portable, and secure network and automated record system that's interoperable, so I can take that wherever I need to take my services and I can shop. Right now, you don't really shop for insurance companies or for doctors. You're sort of stuck with what you have. And at the end goal of this, you're going to be able to collect larger metrics, not only for your individual care, but I think society as a large can see what is effective and what is not effective or cost effective. And that's going to drive efficiencies. I saw a study, I believe last week, which tracked the population, the workforce in health IT. There are more clerks than there are nurses, and there are 9 times as many clerks as there are doctors. That is a huge amount of overhead, which is killing us. It's not sustainable. You compare that to the overhead in any other automated industry, it's night and day. So how can we use IT to attack efficiency and effectiveness to improve them simultaneously?
Yeah, and you know, the good thing is, we didn't bring it up, but with all the political issues going on about healthcare, this, that, and the other thing, there's no arguments about using health information technology to drive out administrative costs. That's one that's agreed by everybody is something that's important to do, and that's some of the points you're driving home there. Colonel Pak, what's the future look like to you? What do you see out there in terms of where this is all going?
Before I give a quick, I guess, view of my biased perspective on the future, I think what I realized recently when I was giving a talk was that, you know, we have a carbon-based organism. Mm-hmm. And we have a gap, and then we now turn to the computers to have a semantically normalized set of information so we can do predictive analysis and do all the things that we need to do. And we put all the analog in between. So that's the patient taking a blood pressure setting, all the things we do, we document, we punch it into the computer, and then we then try to do all the work in the hindsight. I think what we'll see is that gap shrinking. So less hands-on, it will go more from the patient through biosensors and other means to go straight from computable data to computable data and not convert back to analog. And it's kind of what Doug was talking about from a paper perspective.
I like this a lot.
So I think that's the future. And so what that means is that the role of the doctor will change. And that's what I think Dr. Cowan was talking about in terms of now having a team-based approach. And I think the EHR will look very different. I think it will be a Facebook equivalent of a collaborative type of a tool that will look fundamentally different, in which the patients participate. And I think that obviously the personalized medicine, the genomics, proteomics, the mobile devices, the ability to do diagnostics, and the future will look amazing in 10 years. Yeah.
It's it's like the next version of that virtual physical thing you hear and stuff like that. I mean, I'll take a smart pill, it'll go through my body and talk to the computer and tell everything's going on, send the information. I could use a smart pill, that would be great. Dr. Fridsma, what's your vision of the future look like?
Well, I think, as we've talked about here today, interoperability is not a destination, it's a journey. And so we have a lot of work to do to get there. I think I see a future in the government in which we enable the private and public sectors to identify common solutions and create shared solutions, endorsing a set of standard services, policies that will allow interoperability to occur, and then enforcing compliance so that we can be assured that the security and the trust is maintained. I think the best example is my sister is a primary care provider in a federally qualified health center in rural Michigan. And 2 years ago, when she found out I was coming to the government, she yelled at me at Thanksgiving and told me that I was doing all sorts of terrible things in the government, and we were creating a burden to her practice. Last Thanksgiving, I went back, and she pulled out her iPad, and she showed it to me, and she said, "What you guys need to do is build more apps." And I think we have success when we see those kinds of situations happening out there with the providers.
Yeah, terrific. Well put. Well put. I like the story, too. Stories always work. Let me try to do a little bit of a summary here. Clearly, we heard about a lot of progress with the nationwide health information network and work going on there. It's also coordination going on across federal government. Sitting right here today, we have DOD, HHS, and VA, and all talking about how you're working these issues together. When we talked opportunities, there was a lot about mobile technologies offering tremendous opportunities in the future, as well as telehealth, telemedicine, and the ability to capitalize on some of those things that will be happening in the future as we move forward. We understand there are challenges out there. Culture seems to be one that's a big one. We also have that interoperability challenge, as well as privacy and security that's always got to be kept in mind. But I also did not hear anybody shying away from the challenges. None of them seem to be showstoppers. That they are just that, challenges, and challenges can become opportunities when they're overcome. We've talked about the future, and we've got some great stories about the future in moving the analog versions or the analog things out of the system. We all agree that there's a tremendous amount of churn in the system, administrative churn, that's ripe for automation and ripe for driving costs down, and the political environment is fine for that. Despite what happens with policy around healthcare in the country, there's a tremendous agreement to work on getting the administrative costs down by making the experience for customers or patients much more enjoyable and eliminating all the redundancies that are out there. With that, I want to first thank all of our panelists here for taking time from your busy days to come inform our audience and tell the stories. I think I learned an awful lot here today of things that are going on that I had no idea were going on. So this was a very, very positive discussion.